Yeah,
Afternoon
live
all.
you can. Yeah, you
Good
can.
afternoon all. Welcome to the first session of MIOC Day 2 2020. Uh, I'm glad to announce today this starting of Symposium 5, that is Imagining Neovascular AMD Management by Dr. Ammar Safar and Dr. Prasan Rao. I'm glad to welcome this session speakers, both of them. Dr. Ammar will first talk on the topic why fluid matters. Dr. Ammar is an American board certified ophthalmologist and a highly experienced consultant in VR diseases and surgery. He has undertook his medical training in Syria before moving to United States. He has specialized in ophthalmology in University of Washington, D.C. He has then acquired additional 2 years fellowship in VR diseases at University of Texas in Dallas. Then he relocated to UAE, and he's presently he's a medical director of Moorfield Eye Hospital in UAE. Welcome, Dr. Ammar, and over to you.
Thank you so much, Dr. Devdatta. Let me just share my screen, if you don't mind. Second here. Okay. Okay, so thank you so much, and thanks for, I don't know if you can see my slides right now, probably.
Yes, yeah.
Excellent, thank you. Thanks again and for giving me the opportunity to participate and for the honor to speak in your Congress here. This is my disclosures, and we will be discussing a lot of issues this afternoon in a span of about 15 minutes. So let's go to it right away. The main thing is to talk about fluid in the context of neovascular AMD. So as we all know, the hallmark of neovascular AMD is the presence or absence of fluid. So that's why we call it wet AMD as opposed to the dry type of AMD. And the main problem with the wet type is the presence of fluid, which can actually displace photoreceptors and affect the ability of the retina to function and give us vision. How do we diagnose it? In the past, we used to have only fluorescein angiogram in our examination. Now, of course, we have a myriad of tools, including autofluorescence, ICG, OCT, and OCTA. But OCT remains the key modality that people actually use to determine whether there is or isn't any fluid in the retina. And also, it is the key modality for whether we treat or don't treat and how we monitor the patients. So if you look at the OCT, obviously on the top you see the normal OCT, how it should look, and in the bottom part you see different kinds of retinal or subretinal fluid in general. And like I said, the OCT is by guidelines from so many international retina and ophthalmology bodies tell us that this is the main drive for deciding how to treat or when to treat and how to monitor these patients. So let's talk about the different types of fluid. As we all know, there is something called intraretinal fluid, and then there is also subretinal fluid and sub-RPE fluid. The worst type is actually intraretinal or IRF. The intraretinal fluid, unfortunately, is associated in general. It has a negative impact on best-corrected visual acuity. And the subretinal fluid, on the other hand, is less severe as far as vision is concerned. And some studies have actually suggested that the presence of subretinal fluid might be, quote, protective, although we will talk about this in further detail as we move in this talk. The sub-RPE fluid, on the other hand, there is not a whole lot of data as far as the significance or no significance of the presence of fluid underneath the RPE, although there is now emerging evidence that it could be an early sign of activity or recurrence in AMD. But regardless, if you look at a normal retina, this is how a normal retina should look like: no fluid in any layer or any potential layer. So let's talk a little bit about the CST or center subfoveal thickness variability data. So does it really matter if the fluid fluctuated during the course of treating neovascular AMD? You know, we've always seen this up and down of the fluid. So let's look at the data and see. So in order for us to actually look at this particular question and try to answer it, there was a study looked at the pooled treatment data from the Hawk and Harrier study. And this analysis looked at, to study the effect of variation of retinal thickness on the vision outcome in patients with neovascular AMD. So what they did is they divided or created 4 quartiles. The lowest quartile, which is low variability, so less than 27 microns, and then the highest quartile 4 is more than 68 microns of variation in the fluid. And between them, we have quartile 2 and 3. And then they plotted this against vision. So as you can see here, it's very, very impressive to see when you don't have variation, meaning here quartile 1, less than 27 variation in fluid, the vision is good. And the more variation you have, the worse vision you get. Now, this was Hawk and Harrier. If we look at the Cat and Ivan, they did the same exact analysis for the patients in Cat and Ivan using the same exact criteria. And guess what? The results were very, very similar to what we got in Hawk and Harrier. And in fact, if you put them right next to each other, they look very much like a mirror image of what you get. So the main issue here that we can take from 2 independent studies is that their variation in the presence of fluid underneath the subfoveal area does actually associate with worse vision. The more variation you have, the worse vision you have. And this is very evident in this graph here. You can see when you have low variation, vision is good. When you have high variation, vision is not good. Now, is there a correlation between the variability of the CST and fluid? So basically, if you have a lot of variability, does that mean you have a lot of fluid or not? And let's look at that. When we look at these quartiles here, again, low variability versus high variability, and put that against fluid or plot that against fluid, you also see the same conclusion. So when you have low variability in the thickness, the likelihood of having fluid is low. When you have high variability, the likelihood of having variation and fluid is high. So from that, you can actually conclude from looking at this data that you get much better, best corrected visual acuity gains if you have lower variation in the center thickness underneath the fovea. And if you have variation, you have fluid. So this has been looked at in Hawk and Harrier and been looked at Cat and Ivan, and they looked very, very similar in results as we saw. So if you try to look at even further, trying to use AI, artificial intelligence, and try to apply the amount of data, the wealth of data that you get from these studies into the AI, you get quite a bit of information, as we're going to see here. So looking at Hawk and Harrier, as you remember, this is the treatment schedule. You have the initiation phase, which is the first 3 months, and then you have the maintenance phase. And every patient in this study, regardless of what they got, actually received an OCT image and best corrected visual acuity measurement on every visit. So that resulted in a huge amount of images that can be fed into the AI machines, and using specific algorithms, try to get some data in a very objective way without any bias to see about the variation of fluid and about what can we draw from this data. So let's look at it, and let me try to orient you here, because these look like EEGs, if you ask me initially the first look. So basically on the top part you have Hawk, on the bottom part you have Harrier, and the green is aflibercept, the red is brolucizumab. And this first slide here is looking at the first injection. So if you have a patient with fluid and you give them the first dose, what is the effect of the first dose? And you can see that there is a very robust effect reducing the fluid using either one of them, using aflibercept or brolucizumab. This is looking at intraretinal fluid. So looking at the fluid that is the worst type of fluid, as we discussed earlier, you can see that they are both very effective when you give the very first dose. If you look at the subretinal fluid, you start to see some variation between the brolucizumab and the aflibercept, and you start also seeing a little bit of that seesaw that we are familiar with aflibercept, that variation, which we have already established is not really a very good thing to have. If you look at the PED or sub-RPE fluid, you start really to see some dissociation between the two graphs, between aflibercept and the brolucizumab. For here, you can really see that the brolucizumab actually gave a lot more stable and effective resolution of fluid with the sub-RPE component. Now, this is a very important, I think, a very also powerful information, because this part here basically try to forget about what you're getting. You're not really comparing anymore between aflibercept and brolucizumab. You're basically trying to see there is disease activity or low disease activity, high or low. How do you define that? You define that by the presence of fluid or the low presence of fluid. So if you take these patients and I try to actually plot them as high disease activity, with defined as you can see here with the presence of a lot of fluid, versus low disease activity, and try to see how these patients do as far as vision is concerned. This is very important and very powerful. And if you don't remember anything from today's presentation that I gave you or that I'm giving you, please remember this, because this is very, very significant information. It is treatment agnostic, which means it doesn't matter what you're using, whether you're using aflibercept or brolucizumab. What it's showing you here is that with the intraretinal fluid, subretinal fluid, and in the sub-RPE fluid, if you are if the amount of the disease activity is low, vision is better. The disease activity is bad, the vision is bad. So this is very beautifully depicted in this slide, where you can see when you have highest disease activity group, vision was not very good. When you have low disease activity, meaning low fluid, the visual acuity was better. So from that, you can say that yes, with the intraretinal fluid resolution after the first dose for patients with avascular AMD, both brolucizumab and aflibercept were quite potent and achieved a rapid and good resolution of the intraretinal fluid. However, the brolucizumab was consistently better than aflibercept in reducing the subretinal and the sub-RPE fluid. And then, like I said, if there is high disease activity, meaning a lot of fluid, then the vision is not good. If you have low disease activity, the vision in general is better. So to answer this question here, yes, I think definitely the answer to this is yes. It does matter if the fluid is fluctuating in as far as vision is concerned. How about early drying? So basically the question here is does it really matter if we dry these patients early, as long as we're ultimately going to dry them out? So why the issue about drying them fast? So let's look at the data and see what that helps us with. Again, we're taking Hock and Harrier and doing analysis on that. This is a post-hoc analysis looking at pooled data and basically trying to answer this question. So after the patients have been actually treated for 12 weeks, you look at, you take them all, both groups, brolucizumab group and the aflibercept, and then you divide them into two groups. So at week 12, if the patient has no fluid on their OCT, they go to the green group. If they have some fluid, regardless of what medication they're using, they go to the red group. And then you follow them over weeks until the end of the study at year 2. And this is a very, very important also information you can see. So as you can see here, at 12 weeks, if you were dry, you continue to be consistently dry all throughout the 96 weeks. While if you were not dry, you're getting this fluctuation, which again, as you remember, fluctuation is not very good. If you look at the vision, vision is significantly better if at week 12 you had completely dry retina and continued the treatment, you continue with very high levels and very good levels of vision, as opposed to if you were not dry at week 12 and continued the treatment. So you really never match it. They are parallel and not really meeting or intersecting at any point. Are there limitations to post hoc? Of course, it is a post hoc analysis, so the conclusions from that could be limited. And also, they did not account for the type of the lesion in this AMD. But again, this is a very significant information, in my opinion, that tells us that the faster we dry these patients, the better. So does it really matter if it's important to dry them early? I also think the answer to that is a definite yes. Now, those are all controlled studies. Of course, Hock and Harrier were randomized trials and controlled trials. How does that really look in real life, in real practice? So this is important for us. And if you review the literature, and this is a very important study that we're going to look at in the UK, they took these patients and looked at the two objectives, basically, from this study was to see, first of all, the OCT markers that we're talking about, the presence of the fluid in all these compartments, and the visual acuity, are they correlated with each other or not? And the second objective was the decision-making for doctors. So what are doctors actually relying on to decide to retreat or not? So after looking at these patients and making exclusions that to improve the quality of the study, they looked at these questions. And sure enough, there was a positive correlation between the absence of fluid on the OCT and the potential visual gains. And also, patients or doctors actually were more likely to depend on the OCT markers to make the decision on retreatment as opposed to depending on the visual acuity fluctuations. And the studies actually show that in this study that the main thing they looked at is the intraretinal and subretinal fluid a lot more than the PED fluid. So that is something that we're actually, I also would admit, we always considered in a sense that the fluid under the RPE is less severe or less dangerous than the subretinal or intraretinal fluid, which probably should be looked at again and changed again. So from this, you could also conclude from this particular review, like I said, that the physicians are basing their decision to inject on visual, not only on visual acuity, but actually on the presence or absence of fluid on OCT. So what I'm going to do right now is just to give you a summary of take-home messages that I'd like you to really understand. First of all, it is my opinion really that all retinal fluid is considered a disease state in the context of AMD. I honestly never bought into the idea of tolerating fluid in the retina in the context of neovascular AMD, exactly like we, in my opinion, in my training and in my practice, I don't tolerate any cells in the eye if there is uveitis, for example. But the idea here you need to understand, I think the data that we have looked at so far does actually prove that lower levels of fluid equal better vision, early drying up of the retina equals better vision, and less variability of the fluid also equals better vision. So if you're really after better vision, we better dry them out quickly, do not tolerate any fluid, and do not tolerate any variability as much as possible. So in our choices of what to treat or how to treat our patients with neovascular AMD, I believe we need to pick the medication that we feel will achieve these things in a more potent way as much as possible. And I'd like to thank you for your attention. And I think I am within my 15 minutes.
That was a great presentation, Dr. Ammar. It just gives an idea. AI is the future, and probably most of our this one future studies will be clinical studies will be based on AI, I suppose. So thank you for excellent presentation.
Thank you, sir.
So we'll now move to our next presentation, second one, by Dr. Prasan Rao. He will be talking on new era in wet AMD management. Dr. Prasan Rao, as you know, he needs no introduction. He's a well-known figure in an authority in retina all over Gulf. He has done his FRCS and post-graduation. At present, he is a medical director, specialist ophthalmologist and vitreoretinal surgeon at Medcare Center in Dubai Healthcare City. He was the first to perform 27 gauge vitrectomies in UAE. He was the first to introduce scleral buckling as well as lens sparing vitrectomy in UAE, and as well as management of retinal detachment in ROP. He has received many coveted awards, a few from American Academy of Ophthalmology as an International Ophthalmologist Education Award, also an Scholars Award from AO. He's a reviewer for Middle East Journal of Ophthalmology. He has various presentations, and he's done various instruction courses and lectures as an invited faculty. So without wasting time, I would like to welcome Dr. Prasan Rao and start his presentation. Thank you.
Prasan, you're muted.
Prasan, you are muted. Can you?
You're muted.
Dr. Prasan, you are muted.
Yeah.
Can you unmute yourself? Yeah.
Can you hear me now?
Yes, please.
Yeah. So thank you, Dr. Rashid and Dr. Devdatta for the kind introduction and for giving me an invitation to speak. At the outset, I would like to say that my talk actually follows what Dr. Ammar said. So I'll be talking about new era in neovascular AMD, and the In the past few decades, we have seen an evolving spectrum of neovascular AMD treatment. In the early 1980s, we had no treatment, at which point of time patients with neovascular AMD lost vision. Then in early 1980s, we had the thermal laser, which halted disease progression. And then we had the photodynamic therapy in early 2000s. In 2006, the anti-VEGF was introduced. And from then on, a search for a better anti-VEGF medication has always been there, primarily to look for agents which have increased durability, which improve the anatomical outcome, reduce the treatment burden, and have sustained long-term visual gains. So the current generation of neovascular AMD medications are subdivided into three classes: the anti-VEGF group, the bispecific antibodies, and the antibody bipolymer conjugates. So the anti-VEGF medications include brolucizumab, abicipar, pegol, and combercept. And the bispecific antibodies include faricimab and KS, and the antibody biopolymer conjugate includes KSI-301. So in the next few slides, we'll see how these medications have been doing in terms of treatment in neovascular AMD. So let's talk about faricimab. It's the first in this class bispecific antibody, which is designed for intravitreal use. It primarily binds to VEGF-A and to Ang2. So Ang2 is a protein which binds to the Ang2 receptor, and it causes increase in the inflammatory cytokines and causes release of fluid and leakage. So anti-Ang2 is one way, helps to stabilize the leakage and prevent leakage in neovascular AMD. So this molecule has been designed for a faster systemic clearance, and it was studied in the Stairway summary trial, which looked at faricimab 6 milligram given every 16 weeks and every 12 weeks, which was compared to ranibizumab every 4 weeks. And about 65% of faricimab treated patients had no disease activity at week 12, and there were no safety signals as well. Currently, there are 2 phase 3 clinical trials, the Tanaya and the Lucerne clinical trials, which have completed their registration. The next, we look at combercept. Now, combercept is a recombinant fusion protein which binds to VEGF receptor 1 and 2. It is similar to the aflibercept molecule with an additional binding ligand, and it targets VEGF-A-B, placental growth factor, and binds to VEGF-C as well. This is approved in China for the treatment of neovascular AMD since December 2013. The Phoenix results showed that combercept had better visual gains as compared to sham. It was well tolerated and did not show any adverse side effects. And currently there are 2 trials, the Panda 1 and the Panda 2, which are global phase 3 trials, twin trials, looking at 2 doses of combercept, 0.5 milligram every 8 weeks and combercept 1 milligram every 12 weeks versus aflibercept every 8 weeks in neovascular AMD. The newer therapeutic molecule, which is KSI-301, is an antibody biopolymer conjugate, which is a new class of molecule which has been designed to improve the bioavailability, stability, and increase durability. It targets all isoforms of VEGF-A. Currently, this is a new medication, so only phase 1 interim results have been published. That was with 3 loading doses of this medication, and to look at sustained disease control for more than 4 months in about 84% of the patients. Again, there were no safety signals with relation to this medication. A trial has been ongoing, which is known as the DAZZLE trial, which is a phase 2 study, which looks at the efficacy and safety of this molecule, 5 milligram, but tried over every 12 weeks, 16 weeks, and 20 weeks versus aflibercept 8 at every 8 weeks. Another new molecule which is available in the UAE at this point of time is brolucizumab. So this is a clinically advanced single-chain antibody fragment, which has been specifically designed for ophthalmic use as a potent inhibitor for VEGF-A. Note its size, it's only 26 kilodaltons, and because of its very small size, it has more drug per dose. So the molar concentration is much higher than that of aflibercept and ranibizumab. And this achieves effective penetration through the retina and choroid. It has been specifically engineered to achieve more drug per injection and also for rapid clearance. So the registration trials of brolucizumab were the Hawk and Harrier trials. So these were 2-year randomized trials, double-masked, carried almost all over the world. The Hawk was primarily in the US sites and Harrier was ex-US. It looked at non-inferiority of mean best corrected visual acuity versus aflibercept. And there were 2 doses in the Hawk which was at 3 milligram and 6 milligram versus aflibercept 2 milligram. And in the Harrier, brolucizumab was used as 6 milligram and aflibercept 2 milligram. So I'm not going to go in detail with how the trial was conducted, but I want you to just look at there are two phases, the match phase and the maintenance phase. In the match phase, both brolucizumab and aflibercept were given on similar dosing at 0, 4, and 8 weeks. And at 16 weeks, which is an important time point in the clinical trial, a disease activity score was assessed. And based on the disease activity, the patients would either be treated with brolucizumab every 8 weeks, or they were given injections every 12 weeks, whereas aflibercept on maintenance was given every 2 weeks as per the label. So let's go to the visual acuity results. If you look at the visual acuity change from baseline to week 96, brolucizumab versus aflibercept, you can see they had almost similar results at the end of 96 weeks. Please note that this is a non-inferiority clinical trial, and the patients were given at injections at 8 and 12 weeks. So there's a possibility that eyes which could have been treated with brolucizumab could have a better vision as well. Brolucizumab achieved superior registration in CST from baseline. So these are the OCT figures. Again, you can see at the end of 96 weeks, there was better control over the fluid in the HAWK as well as in the Harrier trial. In both HAWK and Harrier, fewer patients on brolucizumab had intraretinal fluid and subretinal fluid at week 16. So I wanted to concentrate on the green bar, which is the brolucizumab 6 milligram, and on the right, which is the aflibercept, which is the gray bar. And at every time point at 16, 48, and 96, there was statistical significant difference between the two molecules, both in the HAWK and the Harrier trial. If you look at the subretinal fluid, again, eyes treated with brolucizumab did better. They had fewer patients with subretinal fluid at week 16, 48, and at week 96 in the HAWK, and in similar results in the Harrier trial. So just to summarize the visual and anatomical outcome of this thing, brolucizumab was non-inferior to aflibercept. The best corrected visual acuities with brolucizumab were maintained at week 96, and fewer patients had intraretinal, subretinal fluid, and fewer patients had sub-RPE fluid when treated with brolucizumab at week 16, 48, and 96. Brolucizumab had also superior reduction in CSTs, and fewer patients of brolucizumab had disease activity at week 16. So this was a head-to-head comparison with similar dosing of brolucizumab and aflibercept. Now let's look at the fluid results. So when you look at the fluid results, as Dr. Ammar said, fluid is a very important thing. So let's look at the post-hoc fluid analysis at week 96. So we are looking at patients who had resolution of fluid now. As Dr. Ammar said, if there's no fluid, that's what we finally want to achieve. There's complete fluid resolution. That means absence of subretinal fluid, intraretinal fluid, and sub-RP with brolucizumab at the various time points. And these are all statistically significant, and similarly in Harrier as well. Let's look at the time to dry. So if this is a post-hoc analysis trying to look at the time to dry, which is eyes with more than or equal to 3 consecutive fluid-free follow-ups. So the time to sustain dryness with brolucizumab was achieved in 96 percentile of patients at week 32 with 3.3 injections. So that is much lesser as compared to aflibercept, which was achieved at week 56, and patients required 5.4 injections. So patients required more injections with aflibercept and required a longer period of time to dry up. Similarly, in Harrier, similar results. The drying was achieved at 20 weeks and 2.6 weeks and 2.6 injections with brolucizumab versus aflibercept at 52 weeks. So the post-hoc fluid analysis for this would be more eyes achieved fluid resolution with brolucizumab. There was sustained dryness earlier and faster with brolucizumab as compared to aflibercept, and this brolucizumab achieved better disease control than aflibercept. Let's try to look at eyes which had early persistent subretinal fluid. So what happens is when you treat these patients and they have persistent subretinal fluid, this was defined as the presence of fluid at baseline week 4, week 8, and week 12, and the patient received identical dosing with brolucizumab and aflibercept. At week 16, you can see that the patients had similar, brolucizumab had fewer number of patients to start with as compared to aflibercept. If you look at the visual gain over a period of time, eyes treated with brolucizumab did much better at week 96 in terms of the visual acuity. If you look at the percentage of patients who achieved better vision at more than 15 letters at each time point of time, at 16, 48, and 96, the brolucizumab generally tend to do better. Even for significant reduction in subretinal fluid levels or CST's reduction, eyes with brolucizumab did better at week 96 versus aflibercept. So here you had lower portion of brolucizumab treated patients than who had persistent subretinal fluid, and eyes treated brolucizumab had better vision. They gained more than 15 letters in more percentage of patients, and they had better reduction of fluid or CST in these patients. Lastly, we are also trying to look at Q12 dosing status, which is the predictable outcomes with Hawk and Harrier. So there are three things I want you to remember. Every patient, over 50% of the patients on brolucizumab 6 milligram, they maintain Q12 dosing until 48 weeks. So when these patients were given three injections, 50% of our patients would require injections every 12 weeks. And also this was the first trial which looked at the predictable outcomes. It would give you the probability of how many patients would require Q12 interval. So over 80% of brolucizumab required 12 weekly interval injections up to week 48. And similarly, if you look at the 96 week results, over 75% of patients treated with 6 milligram of brolucizumab would require Q12 intervals. And this was remained until week 96. So these are 3 points when you treat patients with brolucizumab. Over 50% of patients treated with brolucizumab were maintained on Q12 immediately after the loading phase. And if these patients continued on Q12, 80% would remain on Q12 till the first 1 year. And in the second year, almost 75% of our patients would remain on Q12 till week 96. And my last part here is the safety outcomes with respect to brolucizumab. So when you look at trials in Hawk and Harrier, they found that the safety profile was almost similar in terms of there are no systemic signals which indicate problems between the two medications. We look at the ocular safety profile. So according to our ocular safety profile, intraocular inflammation was one thing which stood out, and almost less than 1.1% of these patients had intraocular inflammation, both in the aflibercept and the brolucizumab arm in Hawk and Harrier. However, after its registration, there were some cases of intraocular inflammation which were reported. So in the month of February and March 2020, Novartis actually decided to set up its own safety review committee, which tried to look at the cases which are reported having intraocular inflammation, and also tried to look at eyes which had intraocular inflammation in Hawk and Harrier. And they came up with this conclusion that less than 1% of, if you look at the overall intraocular inflammation rate, it is 4%. Intraocular inflammation plus retinal vasculitis in about 3% of the patients, intraocular inflammation vasculitis with occlusion in 2% of the patients, and less than 1% of these patients lost vision. But more importantly, the safety review committee reported that the overall rate of visual loss between the two drugs, aflibercept and brolucizumab, was almost similar. So the important thing was a think tank was established to try to look at 4 key questions. What is the root cause of this inflammation? How can we characterize patients at high risk? What can be done to mitigate the incidence of this? And how should these events be treated? So an article has been published in Ophthalmology Retina, giving an expert opinion on how these can be managed. To sum up my talk, we look at the visual outcomes. So brolucizumab did better at week 48, and this was maintained at week 96. The anatomical outcomes were also better. The disease activity was lesser in brolucizumab group at week 16, which was a head-on-head comparison with aflibercept. And 50% of these patients maintained Q12 dosing for the entire period of 48 weeks. And it had a very predictable result. More than 80% in the first year and 75% in the second year required Q12 interval. And for safety, it is a well-tolerated medication. We are now learning to use this medication and realizing that safety is an issue, but we can still manage it. We don't see it very often in our real day-to-day life practice. Thank you for your kind attention.
Sir, you're on mute.
That was a great presentation, Dr. Prasan. We are heading to a very exciting future in wet AMD management, it seems, with so many new molecules in pipeline. So we have come to a last segment of this session, and we'll move to a case-based discussion. Dr.
Ammar. Dr. Devdatta, I'll just continue with my cases. There are just 2 of them, short cases. So okay. Just to show how we use anti-VEGF in a clinical practice, this is a 56-year-old lady who presented in 4th of September 2016 with reduced vision in the left eye. She had a stent done in 2014. She had multiple confluent drusen, and the left eye showed a choroidal neovascular membrane. She was a self-paying patient and she required anti-VEGF treatments. So this is a vision, this is the OCT, which shows the presence of a fibrovascular type 1 PD. And she also had fluid on either side, and she had this subretinal hyperreflective membrane. She was treated with 3 injections of ranibizumab, and her visual acuity improved from 0.3 to 0.5. You can see the significant reduction in the subretinal fluid and the disappearance of the shrum in this case. She was followed up at 6 weeks as per the treat and extend protocol, and you can see the macula is still dry. So at this point of time, another injection was given, and she was asked to come at 8 weeks follow-up. Though her vision dropped a little bit because there was no fluid and the retina was dry, we decided to continue her with the injection. So now she was given an injection, and this is at 8 weeks since the previous one, and asked to come at 10 weeks. But just a few days before a 10-week follow-up, she came with a reduction of vision. You can see the presence of fluid here, some presence of interretinal fluid as well. And then she was given an injection. And this point of time, as per the treat and extend protocol, we decided to reduce the time period. So instead of 8 weeks, she was now called at 6 weeks for an injection. She came at 6 weeks. Her vision was 0.4. She was maintaining that vision. And again, an injection was done, and we continued to give her injections at every 6 weeks. Note the presence of outer retinal tubulations here, and you can also see that when she came back after 6 weeks, at this point of time, as I told you, she's a self-paying patient. She was not keen to continue with PRN treatment. She wanted to continue with PRN treatment, and then she came in October 2017. This is a vision, but she had fluid here. So another injection was given, and there are various changes on the OCT. You have the outer retinal tubulations, you have the RPE atrophy here present. She followed up in Jan 2018. The vision is 0.4. You have the subretinal, interretinal fluid, interretinal cysts which are present, and then she was given injections again. So finally, to cut this long story short, she's presented in October 2018, maintaining a vision of 4.4. We are currently doing her injections every 4 to 6 weeks, and she's maintaining good vision. So the take-home message from this case is that these patients require repeated injections at periodic interval. Long-term follow-ups are necessary, but they would maintain the vision very well. My second case is an 89-year-old gentleman with left eye multiple injections of aflibercept done elsewhere. His previous OCTs did not show any significant improvement. The last injection was done at 6 weeks. This is his vision. He presented on 7th of September with a visual acuity of 4.2. You can note the OCT. He's got vitreomacular traction, large interretinal cyst. You have a subretinal hyperreflective band present. You also have RPE elevations with some hyperreflectivity over the Brooks membrane. So having not responded very well, I decided to give a brolucizumab. We discussed the option of an RPE RIP. This is how we responded with a significant reduction in the RPE fluid. There's a little fluid still present, so we decided to treat her with the second injection, and his vision improved significantly from 0.2 to 0.5. So my point here is brolucizumab is a very good medication. It is good for patients who are resistant to other anti-VEGF. And over a period of time, we'll have our own experience of how we are going to treat these patients with brolucizumab. Thank you for your kind attention.
Yeah, that were great results, Dr. Prasan. I would like to request Dr. Ammar to put in short videos of his cases.
Yes, sir.
We are short of time. We have 5 more minutes.
We are very short of time. I'm sorry, but I will try to be very quick in my cases just to make a couple of points here. Can you confirm if you can see my slides, please?
Yes, doctor. Go ahead.
Excellent. So, in fact, actually, I need to start from the beginning. I'm sorry. So let's go to case number 1. Case number 1 is a 78-year-old gentleman with a neovascular AMD in his left eye. His visual acuity 20/30 in the right eye, 20/80 in the left eye, normal anterior segment, and no treatment is needed in the right eye. So this gentleman basically comes in and gets injections with aflibercept, and basically I always look at his images, and there's always this blue area which is sub-RPE fluid, and there's always a new area of subretinal fluid that shows here and there. And with injections, the subretinal fluid typically goes away, but the RPE elevation here never goes away. And I kind of, got used to seeing it always, and just to when I made this slide here, just reviewed it and really looked at the fact that they never really changed with all of these injections that we've been giving him. Then we went into the lockdown for a couple of months, as you know, here in Dubai. And then the patient comes in, unfortunately, with drop in vision. and a significant amount of fluid, as you can see here, although that blue area remains the same and nothing changed. So at this point, I basically injected him, but this time we have brolucizumab. So I noted initially a sudden or very robust resolution of the subretinal fluid, but then with the second injection, for the first time ever, I see that the injection had actually resulted also in a significant resolution in the or flattening of the RPE, something that this is before on your left and after, something that I really feel is a big thing for me, and I've been noticing this a lot more. So this is something just I wanted to present this case to show you that brolucizumab actually is effective not only on the subretinal fluid but also sub-RPE fluid. I'm going to go on to the second case, which is a challenging case. I was asked to present a challenging case. So this guy here, again, he's Portuguese, lives half of his time here and half in Portugal. And this is his left eye. He's been actually, this is in the beginning of 2019. He was dry in this eye. We were treating his left eye. Right eye. So back in March of 2019, this is the first time he started having some changes in the left eye. As you can see, sub-RPE and intraretinal cyst here. So the first aflibercept was given to him, and he had good resolution in the subretinal and the intraretinal fluid, but the RPE also did not really change that much. Then he continued to have injections, but he went to Portugal for a month or two, so he didn't get any injection here. But then, as you can see here, a series of injections of aflibercept, 7 injections, as you can see here. And then looking at him here, this is exactly why I wanted to present this. From basically March of this year, throughout the lockdown until October, he has been injected on a monthly basis with aflibercept. And as you can see, almost unchanged, completely unchanged from a fluid standpoint. There is significant intraretinal cyst and significant sub-RPE fluid. And this is basically where we are right now in this gentleman. I saw him just a few days ago on the 24th of this month, and this is how he looks. This is why I wanted to present this, because supposedly we were treating this patient with the best medication we have and really have not gotten anywhere, as you can see here. So I discussed with him the presence of brolucizumab and my short experience with the medication, and he was very keen to actually do the injection. So we did it on the 24th of November, but I still do not have any results, of course. But like I said, this presents like an unmet need really that we have, and hopefully brolucizumab will be able to fill some of that need. And these were some of the options, unless you also have anything for discussion. Thank you so much.
Yeah, thank you, Dr. Ammar. With that, we have come to an end of this session. On behalf of MIOC and Ophthalmology Center AFH, I would like to thank both speakers for sparing their time from their busy practice. Dr. Rashid has expressed apologies because he cannot attend the session. Just put a message in the chat box. So thank you so much again, and hope to see you again.